All right. Good morning, everyone. Thank you so much for joining. We're going to give folks a few minutes just to join the webinar, then we'll go ahead and get started. All right, we still have a few folks joining, but we'll go ahead and get started just to keep us on track for time. Good morning, everyone. My name is Meredith Farsani. I am the Training and Engagement Specialist here at the Maryland Coalition Against Sexual Assault, and I'm so excited and happy to welcome you all to today's webinar on sexual violence in detention, the detention environment and trauma-informed care. A few Zoom housekeeping items before we go ahead and get started. Because we are in Zoom webinar, participants are in listen-only mode. So please utilize the chat box in the Q&A function for any questions you have during today's presentation. We will try and answer those throughout, but we also will have some time at the end, or we can always follow up with an email for any questions that folks may have. We do have closed captioning enabled. You can toggle that on and off through the bottom bar of your Zoom screen. You should see the three dots that say more, and then you can click on captions and customize those to your needs. And we will be recording today's session. So if you have to leave early or if you want to review some information afterwards, that will be sent out in a follow-up email, along with the evaluation survey that we have for today's session. If you are seeking a certificate of attendance or CEUs, you will need to fill out that evaluation. So it will pop up when you close out of the webinar, but it will also be sent out in a follow-up email in case you happen to miss it. So if you have any technical issues today, feel free to message me directly. My name is listed as Maryland Coalition Against Sexual Assault. So you can just send me a direct message and I'll be able to help out in any way that I can. But without further ado, I would love to turn it over to our presenter for today, Grace Rupp, who is MCAS's Sexual Assault Forensic Exam, Sexual Assault Response Team, and Prison Rape Elimination Policy Specialist.
Thanks, Meredith. Good morning, everybody. Welcome. Excited to have you all here today. Please feel free to introduce yourself in the chat. Say good morning to everybody on the webinar. But I am going to get us started. Today's webinar will focus on sexual violence in detention, the detention environment, and the importance of trauma-informed care. So we have three key learning objectives today. First, we will review the breadth and dynamics of sexual violence in detention, focusing on a variety of identity markers. And then we'll provide general information about the incarceration environment and explore the value of trauma-informed care when working with incarcerated populations. Like Meredith said, we're going to keep our eye on the chat. If there are tech issues, I'd recommend reaching out to Meredith, but feel free to pop any questions you have in the chat. If I miss them, I will review them at the end and work to get to them. But before we get started on these learning objectives, I do want to highlight my own use of language throughout this particular webinar and presentation. I'm going to switch between the language of victim and survivor. Victim is the term used in the PREA statute and state policies. Survivor is generally the term that you'll see in advocacy spaces or MCAS's webinars. But additionally, inmate and prisoner are used interchangeably. Prisoner is generally the preferred term for people who are incarcerated because it reflects the reality of their situation. And inmate is generally used, the language used by the government. Regardless, generally best practice to reflect the language of the person that you are working directly with. I do want to highlight and wish everybody a happy Sexual Assault Awareness Month. It is SAM. But before we move on to our learning objectives, I do want to highlight this year's theme, which is drawing connections, prevention demands equity. We can trace a line from sexual violence to other systems of oppression, and we cannot work to end sexual violence without also ending other systems of oppression, specifically racism. This SAM calls on individuals, communities, organizations, and institutions to change ourselves and the systems surrounding us to build racial equity and respect. Systems of oppression such as racism, sexism, classism, ageism, ableism, and others contribute to higher rates of sexual harassment, assault, and abuse. So often we are unaware of how historical conditions have shaped our lives and how we move throughout the world, specifically forms of privilege with the many identities that we hold. As such, we recognize that it will take ending all forms of oppression to end sexual violence. Drawing connections between ourselves, our histories, and the world around us is necessary for changing the future, especially when thinking about privilege and oppression and ending sexual violence. This April, during SAM, we want to seek to learn how to draw connections between various forms of oppressions and the underlying causes of sexual assault. In addition, this SAM offers us an opportunity to explore how certain groups of people are at higher risk for sexual violence and how those same people are often those who face the most challenges in seeking support and accessing services. Incarcerated survivors are often a survivor population that does not get as much attention or focus during SAM or throughout the year. I'm particularly thankful for your attendance and willingness to learn more about supporting this population of survivors. Specifically, incarcerated survivors face unique challenges when compared to non-incarcerated survivors. They face challenges around access to support and resources, reporting, and the ongoing impacts of being incarcerated and higher risk of victimization. At MCASA, we believe that every survivor deserves access to support and healing, regardless of their incarceration status. No one deserves to be sexually assaulted or harassed. For incarcerated people, rape and sexual violence should not be a part of the penalty, regardless of what someone has done. Bottom line is that no one deserves to be sexually abused, and rape is not part of that penalty for any sort of crime. It's not an inevitable result of incarceration. There's no good or ideal survivor, there are just survivors. Anyone and everyone can experience sexual violence, and anyone and everyone deserves access to support in their pathways towards healing and justice, whatever that looks like for them. This SAM highlights the need for intersectionality, the need to look across identity markers and draw connections. This SAM offers us an opportunity to look at and support survivors who typically receive less attention, to think about them in their environment, and an environment that often includes multiple and competing systems of oppression. So, moving on to our learning objectives. I'm going to first cover sexual violence in detention at a higher level. In total, there are about roughly 2 million people incarcerated in the US right now. Around 800,000 people are on parole, and about 3 million people roughly are on probation. Maryland specifically has an incarceration rate of 531 people per 100,000 people. I will name that includes prisons, jails, immigration detention, and juvenile justice facilities. Sexual abuse continues to be a serious problem for US detention facilities. Every year, an estimated 200,000 adults and children are sexually abused or assaulted behind bars. The vast majority of survivors are abused multiple times, and about half estimates indicate that abuse is perpetrated by staff, the people who are very charged with keeping inmates safe. I want to name that sexual abuse in detention occurs in all types of facilities, including adult prisons and jails, juvenile detention facilities, police lockups, long and short-term holding cells, and halfway houses. Also occurs in both facilities intended to house men and women. I do want to highlight that I'm going to present a lot of quantitative data today, and I would encourage us to challenge the data that's presented and available to us. First and foremost, the study citing 200 instances of sexual abuse annually was conducted in 2016. Since then, there's been really limited updates on the Bureau of Prisons on that particular statistic. So when we think about this data and this statistic, what story is it telling us? Whose voice is being ignored in this research? What story is it not telling us? How accurate do we think this statistic is? How accurate is this data? And then who is being missed in this data? When we look at Maryland-specific PREA audits, what is the data telling us about the number of incidents? Who is being missed in those audits? I want to highlight that there is a significant and can be, just like for non-incarcerated survivors, difference in the number of reported incidents versus the actual number of incidents. So who is being missed in that gap in research? The reported number of incidents may not reflect the totality of sexual violence in a given institution or in our society generally. So the number of reports are not necessarily a holistic view of sexual violence in a given facility. Again, this is the same for non-incarcerated populations. This is not unique to incarcerated people. The number of reports across the board does not necessarily reflect the breadth of the issue when we look at data for non-incarcerated people as well. I also think this begs deeper questions. So what does the lack of data and research around this population reflect about our priorities? I think it requires us to ask deeper questions. So why haven't we addressed the gaps in research? What does the timing of research indicate about our priorities? How and why are certain populations ignored? The vast majority of research that I see is almost exclusively quantitative. Where is some of that qualitative research being missed? Where is the survivor's voice in the research? Again, I'm going to attempt to provide data throughout this presentation. I am happy to provide you with that research and references after this webinar. But I do want to name that it's really difficult to quantify this issue. And the data I'm going to present typically reflects reported sexual violence. So keeping that in mind throughout the presentation. So I think importantly, this SAM and in general, we want to think about intersectionality on this issue and sexual violence in general. So when thinking about drawing connections and supporting those who've experienced sexual violence in detention, we want to think about intersectionality and those who hold a marginalized identity. These next few slides review the data on particular identity markers and their specific experience with sexual violence. Again, I want you to keep in mind the potential issues with this data that I previously named. And some research doesn't exist for particular groups and affinities. Given that this webinar is only an hour and I want to be respectful of your time, please know I don't think this is at all exhaustive and there are groups that I've had to leave out. But it is intended to highlight the ways in which various identities can be impacted and experience sexual violence differently. It's important to know that these identities do not exist in a vacuum, meaning people hold more than one identity, marginalized or otherwise. The intersection of these identities impacts the ways in which incarcerated people interact with various systems, the ways in which they receive support or don't, and the ways in which they access justice. So the general research shows that people in prison experience physical and sexual violence at alarmingly high rates. 35% of men and 24% of women report experiencing physical victimization. 10% of men and 25% of women report experiencing sexual victimization. So those are just the general overview across identity markers. I want you to keep in mind how might one's identity impact their victimization. So highlighting a few identities specifically, let's look at age. If you wouldn't mind popping in the chat, what barriers do you think youth, so under 18, in juvenile facilities face when reporting? Lack of staffing. Their abusers can be the ones that they're reporting to. No support. Understanding what abuse actually is and being believed. Being believed. Lack of understanding of how to report. Imbalance of power, fear of being believed. Lack of education on the topic and how to report. Fear of retaliation, not being told seriously. Confidentiality. They may face that they're so young that they might be embarrassed. Sure. Believing it's their fault. So all of these are excellent examples of some of the barriers that young people might face. Again, Sarah, thank you for highlighting being believed since their development is different and at different stages than the staff members. Yeah. Fear of being re-traumatized, absolutely. So these are all excellent examples. Thank you for popping them in the chat. But JDI highlights that roughly 1 in 10 youth in juvenile facilities report being abused when in detention. So on any given day, there are roughly 80,000 youth in detention facilities across this country. Nearly 2/3 of youth are convicted for nonviolent offenses. So those can include things like parole violations, drug and alcohol use, truancy. In Maryland, there are 150 youth incarcerated per 100,000 people. Within that, 1 in 10 youth, the stat on the slide, across the board, this is not Maryland specific, report being sexually abused while in detention. Again, I want to highlight that this is reported sexual abuse. This figure might not capture the breadth and holistic view of those who don't report their experience with sexual violence. Again, in a report released by the Bureau of Justice Statistics in 2013, it found that a staggering 81% of victimized youth were abused by a staff member, and most experienced multiple instances of sexual violence. I want to also name that some youth detainees are particularly vulnerable to sexual abuse. So the 2 leading risk factors that are noted in this study are having a previous history of victimization and identifying as being part of the LGBTQIA+ community. So thinking about age here as a spectrum, I want to ask on the other end, what barriers do you think older adults face when they're reporting? So older adults, meaning those experiencing potential elder abuse. Sarah and Deborah highlighted fear, shame. Lack of access to support, yeah. Retaliation, thank you, Jody. You would say it's the same as juveniles, interesting. embarrassed because of age as well. Maybe they feel like they should be experienced or aware enough for their age. So when they do express to someone, they may be judged, feeling as if they won't be heard due to potential past trauma history of abuse, and the cycle is continuing. Thank you, Shannon. Perfect. So here it's interesting. Most of the reasons that you all, or the barriers that you all named, are also barriers that non-incarcerated survivors face, right? Like many people who are non-incarcerated who are also survivors have the same fears, right? Like they fear retaliation, they fear not being believed. Many non-incarcerated survivors also have lack of access to support or even resources in general. I think the age is a really interesting question because it gets to a lot of other intersectional identities, right? When you think of older adults, some older adults face issues around ability, right? Like given their age, they may have mobility issues. What sort of access issue does that also present? So thinking about when people's identities converge and where they meet and how that impacts their access to support. So moving to age, moving beyond age, we're going to highlight gender expression and sexual orientation. So I do want to highlight that LGBTQ plus individuals are incarcerated at a higher rate than the general population. An analysis of data collected between 2011 and 2012 found that same-sex attracted adults were incarcerated at a rate of 1,882 people per 100,000. That is more than triple the national average. When we think about gender identity and sexual orientation, those who hold a marginalized identity are further impacted by sexual violence. Prisoners who identify as being part of the LGBTQ community are among those at the highest risks for sexual abuse and harassment. 1 in 8 LGBTQ prisoners will be sexually abused or assaulted by another inmate in 1 year, according to the Bureau of Justice Statistics. So narrowing that down a little bit, when we look at women specifically, the vast majority of women who are incarcerated, 63%, have been convicted of nonviolent crimes. 62% of women in state prisons, I want to highlight prisons there, are mothers. 75% report suffering from some sort of mental illness, past abuse, or other trauma. And the majority of assaults reported by this population are perpetrated by officers rather than fellow prisoners. Again, that's from the Bureau of Justice Statistics. Lesbian, gay, and bisexual inmates are sexually abused by other inmates at a rate that is 6 times that of the general prison population, and by staff at more than twice the rate of other inmates. Transgender inmates are particularly vulnerable. 40% are sexually abused in detention, either by staff or inmates, which is nearly 10 times the rate of the general population. I want to highlight, again, anyone can be abused while in detention or generally, but this particular population is especially vulnerable to this type of violence. So you can see on the chart here, quantified in a different way with a different visual, some of those numbers. Moving on to physical and mental illness. I think this is a really interesting area, again, getting into ability and that ableism framework. People with mental illness are drastically overrepresented in US prisons and jails. 36% of people in prison and 43% of jail inmates have some sort of mental health diagnoses. I want to name that can really vary what that mental health diagnosis is, and that's based off the DSM-5. Notably, a person with a serious mental illness is 3 times more likely to find themselves in prison or in jail rather than in a hospital setting. Alarmingly, people with mental illness who are sexually abused by other inmates, of that population, 80% report being victimized more than once. So I have a chart on the right that highlights some of what has occurred in the process of deinstitutionalization, that process in this country. So I'm hopeful everyone can see this, but the light blue line is the number of mentally ill patients in hospitals. You can see that between the 60s and the 70s, that number took a real nosedive. And you can kind of see that it continues to drop. The dark blue line represents the number of mentally ill people in prison, which you can see skyrockets, 70s, 80s. Now, I am not advocating for a return to institutionalizing people, but I do want to highlight that with this drop in institutionalization, we want to think about, yep, Dave, thank you for highlighting that. There was never anything funded as an answer or as a response to that. So prisons did become the de facto mental health institutions. So I use this to demonstrate that deinstitutionalization was not replaced with adequate resources or funding or programs for those who needed assistance, right? I want to say that there are many factors at play here. Programs for those who experience mental illness were never and have never been adequately funded in this country. There are Medicaid incentives to avoid housing people with mental illness in treatment facilities because coverage is excluded. But again, there was never an answer to that deinstitutionalization process. And because of that, prisons and jails became that de facto mental health institution. Outside of that, this is a pretty staggering statistic. According to the Treatment Advocacy Center, which works pretty closely with the National Alliance for Mental Illness in this country, there are only 43,000 psych beds in the US as of 2010. That's 14 psych beds for 100,000 people. That's the same ratio that existed in 1850. Our healthcare system is not equipped to support those who are experiencing mental illness. And unfortunately, that means those who are experiencing long-term mental illness or acute mental health crises may get caught up in the incarceration system. Outside of that, when we look at physical health, we also see disparities, especially amongst those older adults who are incarcerated. So 12% of people in state prisons over the age of 55 report having cancer. 12% report having kidney problems. 23% report having heart disease. 23% report having diabetes. 45% with arthritis, and 62% with hypertension. That is not in line with the general population, non-incarcerated population in this country. So I want to highlight now some Maryland-specific data. Currently, there are roughly 117,000 Marylanders behind bars or under criminal justice supervision. So that means that they're either in federal or state prisons, local jails, youth or involuntary commitment facilities, and or on probation or parole. Of that number, the areas with the highest rates of incarcerated people are Baltimore City and the Southern Eastern Shore. So interestingly, I did not know this. Baltimore City is home to 9% of the state's residents, but it's home to 40% of the state's incarcerated population. The three highlighted counties on the Eastern Shore to my right, that's home to 1% of the state's population, but home to 10% of the state's incarcerated population. So thinking again about another identity marker, the disparities related to race and ethnicity as it relates to incarceration. When we look at the incarceration rate in Maryland by race and ethnicity, we can see that non-white people are incarcerated at a rate much higher than their white counterparts. So in Maryland, there are 310 white people incarcerated per 100,000. There are 311 Hispanic people incarcerated per 100,000, whereas there are at least 1,437 people of color, Black people incarcerated per 100,000 people. The latest available data regarding people sentenced to state prisons nationally reveals that Black Americans are imprisoned at a rate that's roughly 5 times that of their white American counterparts. Nationally, 1 in 81 Black adults in the US serving time in a state prison. In 12 states, Maryland included, more than half the prison population is Black. Also, interestingly, want to highlight this graphic compares Maryland incarceration rates to other NATO countries. So interestingly, Maryland is below the national average, but it is still vastly above the national average for other NATO countries. So the number of people we have incarcerated in our state, in our country, is much greater comparatively. So moving on, I want to transition now to thinking about the environment incarcerated survivors exist within. I am going to pop this out to the chat because I think it's really interesting to think about. When we think about a healing environment, one in which people can recover and restore, what adjectives or descriptive language would you use to describe a healing environment? Across the board. So sexual violence or otherwise, what words would you use to describe a healing environment? Warm, non-judgmental, safe. Warm, inviting, safe, safe, safe. Your needs are met. Peaceful, non-confrontational, empathetic, a room full of listeners. Respectful, safe, soft, timely, safe. Resources are provided. Boundaries, yeah, interesting. Perfect. So trauma-informed, yeah. I want to highlight and reflect back to you. These are all great examples. Would you use any of the language that you just put in the chat to describe a prison, a jail, a detention center, an environment where somebody is incarcerated? No. Absolutely not. Yeah. There are islands of safety where I work in prison. That's great. I think it's important to highlight that for non-incarcerated people as well, sometimes those islands are all we have access to. Yeah. So the vast majority of us would not necessarily use healing language to describe an incarceration environment. And I think highlighting, there is a world of nuance in how people experience being incarcerated, and I think we want to be careful of making sweeping generalizations about facilities here. But I would not venture to say that most people in this group would describe this environment as a place where we can heal and restore from sexual violence. I think fundamental to the environment, right, is this control piece. Given the nature of the facility and the ways in which our country and our state manages these facilities, inmates do not have the same autonomy that you and I do, right? Like they do not have the same freedom of movement. And part of that is how the system is set up and the nature of the environment. And that's not to say that's necessarily wrong. But additionally, we want to look at other issues within that. Many facilities in this country are underfunded. Inmates frequently lack access to things on the outside that can provide healing to them. Unfortunately, there are many, reports and instances where inmates have also reported lacking access to their basic needs. So thinking about rehabilitation support, mental health services, medical care, basic human needs like hygiene products, menstruation products, toilets, cleaning supplies, right? So those things look very different for incarcerated people and non-incarcerated people. I also want to highlight that given the nature of the environment, many inmates have limited access to their outside social support. So if we're thinking about healing processes and restorative justice and justice generally, so much of that work is grounded in community and in our social support. A lot of that work is done there. So when people are incarcerated, their access to the outside world changes and it shifts. That's not to say they don't have access to outside social support, but that looks very different. Frequently, their access to their community, their family, their friends has shifted drastically. Now, that's not to necessarily say that they lack support within their facility, right? Like there is community within that facility, and that social support does and can and does exist within a given facility, but it has shifted. And that support looks different. That access to social support looks different for somebody who is incarcerated versus non-incarcerated. All right. So moving on, I do want to highlight a particular practice that when we think about healing, I think it can be in conflict with that. So I want to highlight the use of segregation. This is a practice that people who are incarcerated will and can experience. And also be referred to other language you might hear is administrative segregation, disciplinary segregation, protective custody, special housing unit, isolation, solitary, seen the whole used. But segregation typically involves being held up to 23 hours a day in the cell with limited human interaction. Kind of forces idleness, meaning that incarcerated people lack access to the same activities that they would have if they were living in general population. So they don't have access to the same sort of educational programming, community activities that they would if they were not in segregation. This practice can be particularly challenging across the board, but especially for those with mental health issues or prior experience with sexual victimization. Can often be very traumatic or potentially re-traumatizing. But within PREA, I do want to highlight that there's limitations to the use of segregation. This training is not about the PREA standards specifically, but segregation can be requested or used for protective reasons. So it can be used for protection, but I do want to highlight that even if it is used for protective purposes, the person being held for their safety still feels the impact of that isolation. and that idleness. There are many excellent studies and reports on the negative impacts of segregation. But again, people who exist in seg have limited access again to the outside world, but also the programming within a given facility. Segregation is not meant to be used as punishment within PREA for reporting survivors, but it can be used for protection for reporting survivors. This picture on the slide, you can see an example, but typically it's a very small cell. If you work at a facility or you are familiar, I'm sure are familiar with it. But again, I'm happy to share that research with you all if it's helpful. I do want to note that many survivors report, they share that they fear being put in solitary if they report their experience to sexual violence. So it's interesting to highlight, I think, that seg can be presented and arguably a barrier to reporting for many survivors. So transitioning to trauma-informed care. I'm sure all of us on this presentation have highlighted or have some sort of professional training or familiar with trauma-informed care. But the following principles of trauma-informed care generally serve as a guide when working with survivors, incarcerated or not incarcerated. Outside of folks who are survivors, trauma-informed care is best practice across the board. First and foremost, we want to work towards establishing physical and emotional safety when working with survivors and also staff. So I always think it's really worth noting that trauma-informed care applies to the population that we work with, but also to us. Like, we deserve the same sort of trauma-informed care. We should also be working towards building trust and transparency between providers and survivors or the people that we're working with. We want to be able to recognize the signs and symptoms of trauma exposure and what that looks like for physical and mental health. We want to promote survivor-centered, evidence-based care, ensuring that the survivor and the provider are collaborating and discussing mutually agreed upon goals for interactions. We want to provide care that is sensitive to a survivor or a person's racial, ethnic, cultural background, and gender identity. And then again, we want to think about where, especially for survivors of sexual violence and domestic violence, where can we give back that empowerment, voice, and choice piece? So much of domestic and sexual violence, as we know, is about power and control. And flipping that script, giving back voice and choice and or empowering people to use it, it's a really foundational part of trauma-informed care. I do want to highlight that we spent a pretty good deal of time discussing what healing might look like and what the detention environment can look like, and the systems that incarcerated survivors exist within. It's important to remember that trauma-informed care is vital, but equally important when thinking about and practicing trauma-informed care. It also requires us to understand the wider context, the systems that survivors experience and exist within. Not only incarceration systems, but also other systems of oppression. So when serving survivors, we have to think about those systems that I mentioned at the beginning. So for example, sexism, ableism, classism, age, gender, whatever. Trauma-informed care only goes so far if we don't view people in their environment. We cannot fully practice trauma-informed care without also examining the systems of injustice that our clients and survivors exist within. So I think one particularly helpful framework for me when I'm thinking about trauma-informed care and systems of environment, thinking about person in environment. So the person and environment perspective is a guiding principle that highlights the importance of understanding an individual and their behavior in light of the environmental context in which that person lives and operates and acts. I think the person and environment perspective is particularly helpful when thinking about how to best support people who are incarcerated. So typically, person and environment, this theory thinks about an individual and their behavior and seeks to locate it in their influence. So we really want to think about sometimes there are behaviors that we do or that we observe that are difficult to understand or that we view as problematic, right? Or will be described as manipulative or difficult to manage, right? But when we think about that behavior in context, in environment, how do we build empathy? I could see why someone would behave that way when I'm looking at all of these other factors, rather than also just looking at the behavior itself, right? So sometimes I'll hear people describe inmates or prisoners as manipulative. And what I say back to that is manipulation is typically seeking to meet an unmet need. So when we look at that behavior in context, right, in environment, what are we missing? What unmet need are we missing, or are we not missing anything? And there's a different context for this behavior. I think it's really important, it's impossible to understand and support a person without developing an understanding of that person's relationship with their environment. By considering the various relationships and communities that a person has, we can gain an understanding of how that person and environment interact and how maybe there are some causal relationships there that we can look at. I think when working with incarcerated survivors, remembering that survivors are the expert on their own lives, incarcerated or otherwise. Survivors have the understanding of the environment that they operate within, and they are the expert on their lived experience and their environment. I think that's a really helpful guiding principle if you get overwhelmed by the context, right? So the survivor is the expert on their life, and that helps us successfully guide and advocate from that framework. So moving on, I want to highlight trauma symptoms here and what that might look like in a detention facility. So you can see the graphic on the side. There's no such thing as a trauma-informed prison or jail. I'm going to ask back to you all, what are possible and common trauma symptoms that could be especially problematic or dangerous in a prison environment? So what trauma symptoms do we see that might present challenges to manage or present safety risks for a person who's in prison or incarcerated? All right, so if you all don't remember the neurobiology of trauma, I can spiel off. So I'm seeing SISA, impulsive youth, ANX. Would you mind writing that acronym out? Emily says people can be very easily startled / on guard and can end up in violence. So that hyperarousal state that we talk about in neuro, suicidalities. Okay, I didn't. Suicidality, thank you. Self-harming behavior, irritability, forgetfulness. Sure. Fighting, yep. So some other ones that I want to highlight: aggression, insomnia, difficult to manage across the board, let alone your environment. Perfect. So, other trauma symptoms we see that might be difficult in an environment like this, sensory triggers, huge one. Disorientation. Survivors who are stuck in flight, fright, or freeze frequently get stuck in that disoriented state. Confused, irritable, trouble focusing. You might see some of those self-destructive behaviors. You might see some of that suicidal ideation. But survivors, trauma responses, we cannot always control, right? Some of those fight, flight, freeze responses we can't control. And that can create a real problem across the board, right? Regardless of whether you're incarcerated or not. But within an incarceration environment, that can create real disciplinary problems, right? For example, some prisoners are expected to appear calm and follow directions, right, without questioning. A survivor in crisis may feel that disorientation, that irritableness, that anxiety. And if we remember our neuro, you will know and remember that our prefrontal cortexes have really hard times coming online. So that our ability to follow directions is pretty limited. And, that puts us at a spot where we can potentially face disciplinary actions. Following directions becomes a really Herculean task when your brain is stuck in flight, fight, or freeze. In addition, some survivors, report feeling really out of control, and they behave in ways that risk their safety, incarcerated or otherwise. So, for example, many survivors report having suicidal ideations. In an incarceration environment, what are the consequences of reporting suicidal ideation or suicidal intent? When we think about trauma symptoms and environments for healing, the detention environment can potentially exacerbate trauma. So you mentioned in the chat some of those sensory triggers that are always around. Survivors may be forced to interact with the perpetrator. Again, there's a lack of personal autonomy and sometimes movement. There's general lack of privacy. Incarceration environments can be loud, disruptive, and in general, just sensory overload. I do want to highlight that trauma manifests itself in many different ways, and there is no right way to respond. But survivors who are incarcerated often face limitations in accessing the resources for managing those trauma responses, right? So when you're safety planning with a survivor who's incarcerated, your access to those coping skills might and probably will look different. Moving on to trauma before incarceration. So I just want to highlight this because I think personally it's quite interesting. ACEs are adverse childhood experiences, and those can occur between the ages of 0 to 17. They include physical, sexual, psychological abuse, physical and psychological neglect, witnessing domestic violence, having a close family member who misused drugs or alcohol, close family member with mental health issues, having a family member who served prison time, and parental separation or divorce. So 64% also drug use. Yes, thank you, Emily. Of the US population has experienced at least one adverse childhood experience, whereas 98% of the prison population in the US has experienced at least one adverse childhood experience. You can see the numbers go up on the pie charts above. So unknown amount of ACEs, 1 ACE, 2 ACE, 4 or more ACEs. That's over 3/4 of the prison population. So outside of sexual violence that they may experience in incarceration, they are coming in with these adverse childhood experiences. Moving on to my last 2 or 3 slides here, I think trauma-informed care is a really powerful way to think about building safety. So when we think about trauma-informed care, feel free to pop it in the chat. And those that use this language or this vernacular, who do we typically think of? Like, who's using trauma-informed care as a phrase that we see? Social workers, yeah. Therapists, advocates again. Healthcare providers sometimes, yeah. I think there's a general movement right across the board in the last like 5 to 10 years to see the expansion of trauma-informed care. Forensic nurses, shout out. Behavioral health professionals, administration, direct care staff, absolutely. So I don't think I would some administrators necessarily connect trauma-informed care and correctional staff. Now that's my own bias, but I think when we think of trauma-informed care, the principle that stands out to me the most as somebody who works directly with survivors is safety. I would argue that trauma-informed care is an important site of building safety, not only for the survivor, but the facility and the wider community. I think of trauma-informed care in that language, typically within the realm of clinicians, advocates, forensic nurses, but I think it's really valuable to situate trauma-informed care within correctional settings. Oh, thank you, Emily. There's actually a section on trauma-informed care in service for MD state correctional employees. That's awesome. But I would argue that correctional facilities and advocacy orgs typically have different goals, right? Corrections, we're looking at safety and security. Within PREA, they also hold a big investigation piece and outcomes piece. They're also in charge of that safety, that custody and controlling the environment. Advocacy staff are typically looking at that trauma-informed care piece, support piece. Our general focus is on victimization, non-incarceration. And then generally we're seeking to build that confidentiality, rapport, working to listen and believe. That's not to say that those don't intersect across groups. But I think there are different frameworks for doing the work, right? I generally think that the priorities look different for these two groups, but that's not to say that they aren't, intersecting or that these are exhaustive of the two groups. Rather, they're reflective of the environment and the nature of the work. To best serve survivors and leverage those priorities and work well together, how can we identify shared goals? Feel free to share in the chat where you feel like they overlap or where they don't. But for me, I think highlighting safety in the middle of that Venn diagram is where we start to intersect in really important ways, right? So trauma-informed care is a means of establishing safety. Safety for the survivor, safety for the staff, safety for the facility, and the wider community. I would argue that all groups, have an interest in making a given facility safer. Getting people the care that they need is one way to help support the facility's safety, to have it run more smoothly, and to better manage individual trauma responses. When we prioritize trauma-informed care, we prioritize safety. I think that's a value and priority that transcends disciplines. When we think about buy-in collectively, safety is an important area to focus on, and trauma-informed care is one vehicle for establishing it. I do want to highlight that we're getting towards the end of this. There are 2 slides left. I want to be mindful of time for you all. But lastly, I think trauma-informed care and the community. Across the board, incarcerated people deserve to be treated with dignity, experience safety, and support. We know that 95% people who are incarcerated are going to be released at some point. Of those, 80% will be released to parole supervision, meaning that the vast majority of people who are incarcerated will be released to the community. They will be in our communities. They will be our neighbors. They will be our family, our friends. How are we supporting their release process and their reintegration into the community? think fundamental to that is supporting their healing from sexual violence or otherwise. It's an important way to reduce recidivism and establish safety and stability for all. Access to trauma-informed care, access to resources and support, access to advocacy while incarcerated can often serve as an important starting point in that process. If our goal is to reduce recidivism and ensure communities are safer, support, healing, and the overall wellness of incarcerated people is an important first step. I would argue that trauma-informed care is in our collective best interest. I'm going to skip the last slide and highlight some Maryland-specific resources for you all. But survivors have multiple ways to report and receive confidential services while they are incarcerated. So I want to highlight all the Rape Crisis Center hotlines. Go to our website and find those specific numbers. The Maryland PREA reporting number is listed on the screen. That is a reporting number. So that will start to trigger, Department of Corrections and Public Safety action. The Prison Rape and Sexual Assault Confidential Helpline is confidential. That is not a reporting helpline. So if you're working with people who are incarcerated, please highlight the difference in those two hotlines. Outside of that, you are welcome to reach out to me if you have any questions or need more support. I am happy to provide you the research and references for this training, but I just so appreciate your time and attendance this morning and active participation. And I hope you all are having a great SAM and enjoying all the awareness raising.
Thanks so much, Grace. And thank you everyone for joining us this afternoon. Like I mentioned in the beginning of the training, we will be sending out resources and a recording of the session to the email you used to register. And once you click out of the webinar, a evaluation survey should pop up on your screen. Please be sure to fill that out. We will also send the link to that in the follow-up email as well. So thank you all again. I hope you have a great rest of your day. And like Grace said, happy SAM, and we will see you at our next training. So everyone take care. Bye.